Now it is my pleasure to introduce our next speaker. Our next speaker originally comes from Croatia, but he moved to UK, and he works right now in UK as a neurologist, and he will speak about diabetes, neuropathy, and sex. It will be an interesting topic, which could be interesting for any single person, not just with diabetes. And you can feel free to ask him questions regarding the connection between neuropathy and diabetes, and also sexual disorders. So, Dr. Nevajda, please, the stage is yours.
Thank you, Dario. Thank you for giving me the opportunity to speak here today. And just one question for you before I start. Was he really singing?
Yes.
Yes. Okay. Was it good?
No.
So we shouldn't allow him to sing anymore now. Okay. Fair enough. Good. A bit of an apology on the beginning, because the last part of the lecture is actually going to be pointed towards mostly gentlemen here, not ladies, unfortunately, but rest assured it's quite a positive thing, because those problems are much less likely to happen in female gender, so that's good. Okay, if we can start, because we have to push it a little bit because we're running late. So, as a quick outline of today's lectures, what are we actually going to speak about? We're going to say a few words about neuropathy in general, which is going to be very brief. Diabetes linked with neuropathy, as well as neuropathy in young people. Especially, we're going to emphasize a little bit of neuropathy-associated sexual problems in guys and gentlemen, definitely. How to prevent those things, essentially what you can do to help yourself or someone else. And obviously, we'll try to leave a few minutes for your questions at the end. So, I was trying to find the best explanation, how can we define neuropathy as such, and with going through all of our different studies, research, and so on, I believe this is probably the simplest one. Do I have a pointer somewhere here? Yeah. This is probably the simplest one. Essentially, neuropathy is a malfunction of the nerve. It can affect, so the malfunction means the nerve is damaged for some reason, and therefore some symptoms occur. We'll see which ones at the end. And it can essentially affect any location in the body, and it's very, very common. It's very common in patients with diabetes, especially. It's quite common in youth patients. And according to this study, which was quite recent in September, about 7% of youth patients, bear in mind this was limited to patients aged 18 to 27, 7% have some type 1 diabetes patients have some form of neuropathy at presentation, and 22% of them with type 2 diabetes actually have some form of neuropathy as well. At one point or another, about 60 to 70%, which means roughly 7 patients out of 10 are going to be affected by neuropathy during the course disease, which is a very, very significant number. Classification-wise, I wouldn't go in any details here, but obviously we are going to speak about the specific disease which is causing neuropathy, which in this case is diabetes caused neuropathy. So as a brief summary, neuropathy in diabetes can cause essentially 2 different types of symptoms. It can affect single nerves on multiple locations, or single nerves on the same location, or it can generalize on some nerves. And today we're going to focus about chronic sensory motor neuropathy, autonomic neuropathy, and like we said, one of the subforms, actually one of the end effects, erectile dysfunction. So what is neuropathy and how does it present? So usually it presents with that numbness, tingling feeling. It starts in the feet, gradually evolving upwards, affecting your foot on both sides symmetrically, and rises up, let's say, somewhere to the mid-calf, and at that point usually affects the hands as well. The feeling is rather unpleasant. People usually describe it as burning feeling, as itching feeling. Bear in mind, all of those modalities are essentially the same feeling, and what's one of the hallmarks of neuropathy is that you have an unpleasant feeling with previously which was considered pleasant, like pulling your sheet over during sleeping, and the symptoms are usually much worse during the night. Like I said, it can move up to the hands afterwards. I believe that those 2 pictures actually describe it quite nicely symptoms-wise. So what do we do with neuropathy from the clinical perspective? Usually the clinical picture and the examination of the patient is quite sufficient. All of the other tests, like nerve conduction testing, is good for monitoring the condition, but imaging and a biopsy is only seldom used, only in patients which we have a bit of unclear clinical picture. So did any one of you have any of those tests done? You did? Okay. So one of the hallmarks, like we said, you lose the reflexes on the end of your legs. You do some nerve conduction studies if it's needed. Usually it's not needed. And the sense of vibration is usually the first sense you lose with neuropathy. Why is that important? Because it makes you unable to feel pain. If you're unable to feel pain, you don't know that you're injured. If you don't know you're injured, you can get a wound on your legs. And the wound can cause an infection. Infection can cause sore. Sore can cause a deeper infection. Eventually, it can, in extreme cases, end up in amputation, and so on and so on. So what can you do? The hallmark of all of this is prevention, prevention, prevention. So you'll probably figure out during the next 15 minutes that I'm going to point out a few things on numerous occasions. But first of all, you need to take care. You need to take care of your feet. So wash and dry your feet as much as you can, at least on a daily basis, and check them out every time you do so. Your healthcare provider, whoever that is in your country, is it your diabetes nurse, endocrinologist, diabetes consultant, whomever, needs to check your feet at least once yearly, thoroughly, and at least 3 to 4 months on every visit, just a quick look. So, like I said, socks to prevent injury, adequate shoes, and always never, never, never walk barefoot, because this is obviously quite a big issue. How to prevent neuropathy and how to slow the disease progression, they're always three same things. Control of your blood sugar, control of the risk factors, which includes losing weight. Obviously, you don't have, it's a bit hot here, sorry about that. So obviously, you don't have problems with weight, and keep it like that. Stop smoking if you smoke, and try to manage your other risk factors like blood pressure, like hypertension, like high lipids, and so on. So one of the other things, tips and tricks, is try to trim your toenails appropriately. Try to trim them in the straight line to avoid any potential injuries. Why is it? This is from the SAIL study, which we saw that 7 and 22%. Why is it important? Because early screening and better risk factor management may prevent or delay debilitating neuropathic complications, which is at the end what counts. So pain control-wise, probably you know a few things about this. You can use 3 different types of medication. You can use antiepileptics on one side, antidepressants, opioids, alpha-lipoic acid, which is a bit dodgy thing. There is no clear consensus whether it should be used and whether it has any effect or not. So essentially, on the left side, you can see the antiepileptics. On the right side, you can see the antidepressants. You can combine them one with another, but the important thing is if you're already using them, make sure you're not using 2 antiepileptics. You can combine them with antidepressants or the opioids. And if you're using antidepressants, do not combine duloxetine with tricyclic antidepressants like amitriptyline or triptyline, but you can combine them with everything else like we already mentioned. So the same thing. Alpha-lipoic acid, I don't know if you heard about it, but this is one of the antioxidants. It has been quite a big boom that it's going to prevent neuropathy, it's going to treat neuropathy, it's going to cure neuropathy, but so far there has been absolutely no studies which could support those things, and it's being used seldom. It's one of those drugs, when you read through it, it cures everything. So when you think about it, it's very unlikely to be effective. And it's sold in the US as over-the-counter medication. It can be tried when nothing else works, when patients are unable to tolerate those things, but it's very seldom effective. Opiates, my personal opinion is try to avoid them as much as you can, because you can cause more harm than good. Why? Use them for the breakthrough pain when you are titrating the antiepileptics or the antidepressants, but they can cause abuse, they can cause addiction, they can cause the fatal overdose, and especially they can cause further side effects like medication overuse, headache, and so on and so on. So if you use them, ask your doctor, GP, endocrine consultant just to have a look. Maybe this could be changed to something else. Lidocaine patch as the last resort that can be applied for 12 hours in any 24-hour period when nothing else works. So all of those things, which look a bit strange, how can they help the pain? Physical therapy, working with counsel, relaxation therapy, massage therapy, acupuncture devices, staying active as possible actually have a role in painful neuropathy. Why? Because there is an internal system, internal energetic system in the body, which is raising some levels of internal energetics called endorphins, and essentially that system is modulated by any one of those procedures, and it can help to relieve the symptoms in painful diabetic neuropathy. So I have to be really quick, obviously. On the other side, like we said, autonomic neuropathy with special emphasis on the erectile dysfunction. Obviously, it can affect any one of those systems. When you look at the picture, mostly everything is there. Cardiovascular, gastrointestinal, genitourinary, and so on and so on. They can cause symptoms, which we call them clinical. If they don't cause symptoms, they are caused subclinical. So I'm going to repeat the same thing again, like I did. It's a bit emphasized here, that apart from glycemic control, the incidence of neuropathy is associated with potentially modifiable cerebrovascular risk factors, including raised triglyceride levels, body mass index, smoking, and hypertension. And this is the things you can change, obviously with glycemic control, to prevent or further slow the disease progression. Like on this slide, it's quite obvious that since you don't have a cure, most of the patients will develop neuropathy at some point or the other. But obviously, if you can take care of those issues, you can slow the disease progression. So we come back to the sexual dysfunction. Like we said, this is mostly pointed towards gentlemen here. And why is it so important? What do you think? Because it's one of the major contributors of quality of life, and usually people with diabetes, as well as the people without diabetes, find this part most troublesome. So as a brief overview, erectile dysfunction, type of sexual dysfunction, especially in male, is erectile dysfunction, diminished sexual desire, abnormal ejaculation, and so on. And this is the part which is very common in diabetes. So how can we actually define the erectile dysfunction? Officially, we can say consistent or recurrent inability to acquire sustained an erection, sufficient rigidity or duration. But if we just summarize this a little bit, this is an inability to get an erection which is fit for purpose. So on the other hand, how does that sequence actually look like? So the nerve endings, after some sexual stimulation, try to produce something which is called nitrogen oxide, NO. That nitrogen oxide reacts with a few different things, raises levels of this thing which is called cGMP, leading to the widening, dilatation of the blood vessels, and the blood inflow overcomes the blood outflow, and then you can actually ends up with a penile erection. The problem with diabetes patients, there is a suboptimal activity of that NO, meaning that this cycle is broken here, you don't get enough of this one, and that one doesn't produce sufficient blood flow, and as much as the blood comes in, the same amount of blood goes out, and there is a complete inability to sustain a meaningful erection. So how things actually look like, this is for general population. So it's the most common, definitely, sexual problem. This is for the age group 25 to 75, general population. Roughly 15% of people have some issues with sustaining a meaningful erection. Divided in the age groups, in your age group, 20 to 30, in people without diabetes, almost 10% of people have those problems. In 70 to 75 years old, almost 40% of people have those problems. Interestingly, one of the things that was noted, that one of the risk factors essentially for erectile dysfunction is, if I can call it like that, not using it, which means if your frequency of sexual intercourses goes down by less than 1 a week, it's very likely you are going to develop one of those forms, whether it's going to be this age or this age. Yeah. So we come back to the muscular territory, use it or lose it. Okay. Think about it. Okay. Chris? We can come back to the question later on. Okay. Risk factors wise, you're going to see that the same things occur all over again. So we said, can we go ahead or should we stick on that one? Okay, risk factors wise, you can see that same things happen all over again. Obesity, smoking, watching TV, which is essentially reduced physical activity, chronic medical conditions, and diabetes being one of the most common. So therefore, when we look at diabetes, which is obviously intertwined with all of this, when we look at diabetes, at some point in life, your chances of having erectile dysfunction are essentially 50-50 if you don't do anything about it, which is quite a lot. Okay, how does that look like in type 1 diabetes, actually in very young patients with diabetes? This was quite recent as well, September last year, one of the Nature's journal, which shows that in that age group, which was again 18 to 27, type 1 diabetes, about 4 out of 10 patients have some problems with erections, which they find troublesome, which is quite a big percentage. In control group, there was only 6%, only 6 people out of 100, which is obviously a very significant and huge difference. So that's an interesting thing. When you look at the impact of quality of life, this is the one which is on top and increases the depressive symptoms. Why did I bold depressive symptoms here? Because depression is obviously treated with antidepressants, and antidepressants cause sexual dysfunction. And then you end up in a vicious circle, and if no one recognizes this, if no one raises this, which is very likely to happen, obviously things are just going to get worse and worse. So, and to prove that, actually, majority of the men, which is almost 90% with diabetes, have never been asked by a clinician, whoever that is in your country, whether you have any sexual problems. From all of you, you are quite young, but was anyone asked ever? Was anyone asked about any sexual problems from your clinicians? Never. So there's roughly, what, 50 people here? Not a single one. Okay. That's, sorry?
Almost
70. Okay. So that's something for you to work at, definitely, as well. Okay. So interestingly, out of those almost 90%, in your case 100%, very bothersome, not talking about it, people find it in 80% of the cases. Which ones of you would have liked to discuss it with a healthcare provider? Raise your hand. Good. So definitely more than zero. And 69% of people who have problems would like some help. They didn't get it, obviously. Like you as well, they would want a discussion. But 70% of people would like the healthcare provider, whoever that is, like I said, to raise that topic, because obviously it wasn't raised in your cases as well. So that's maybe something which we can do the next time. Okay, what can you do? So as a first step, like I said, you need to initiate the discussion, because it's very unlikely this is going to happen on its own. You need to ask your GP to review your medication, because interestingly, 8 out of 12 most prescribed medications in the world these days are causing sexual dysfunction. So, and that's a very worrying figure, actually. Control of risk factors, you probably figured that out by now, and obviously the hallmark of all of this is blood sugar management. So, treatment-wise, this is a brief chart how to do it. Identify the underlying etiology. Most likely in your age group, the drugs are going to be responsible for it. Identify the risk factors if you have them and try to treat them. And if that all fails, you can provide some medical treatment. Medical treatment-wise, the first thing is, which as the first line is Pde5 inhibitors. This is all of the famous Viagra. You probably all heard about it. And we have a few new ones, Vardenafil, Tadalafil, which is fairly new. I personally prefer Tadalafil, not personally, but okay. So, and the next one is Avanafil, which I don't think it's still registered in Europe, not sure. So what do they do exactly? They, if you remember this cascade with nitrogen oxide, they essentially block this enzyme and increase the level of this one. So they actually annihilate the effect of diabetes to the NO and help you to sustain a meaningful erection. By the way, if you ever require one of those drugs, please do not buy them online. There's been a recent seize of drugs in Canada. They have seized about 4,000 shipments of those drugs. 98% of them were fake. So fake drugs with who knows what, with completely unsafe, with loads of side effects. If you need it, speak to your GP, healthcare, whomever, get a prescription for it and get a good one. Do not buy online.
I have to cancel.
Please cancel the orders if you have any. Okay. Second line and good. At least some good. So second line and third line, self-injectable drugs, intraurethral application. This is something that we always need a bit of help from urology as well, so this is a bit out of scope of this lecture, as well as the surgical options, which are mostly reserved for some deformations, malformations, and so on. So, key points from today: with good glycemic control, with asking for help when you know that you have a problem, and with prevention, and especially in controlling the risk factors like we said, we can sustain a meaningful quality of life, and at the end, I think that's what it's all about. Any questions? Oops. Yeah.
We have time for maybe a few questions, but short questions, short answers, please.
I would like to know how far are we in terms of research as it relates to neuropathy?
How far are we?
Like, are you guys coming close to a cure for neuropathy?
So at this stage, no. At this stage, definitely no. All of those things that were tried, every one of them failed, and all of the treatment is currently pointed to, like we said, glycemic control and risk factor management to slow the disease progression as much as possible.
So the use of Lyrica for neuropathy.
Sorry?
The use of Lyrica for neuropathy.
Lyrica is pregabalin. That's one of the drugs which was,
prescribed.
Yeah.
So nowhere close to it being reversible either.
As far as I'm aware, in the pipeline, no, there is nothing which is even close to the
Okay,
registration.
thank you.
Thank you for the nice talk. What about consumption of alcohol in people who has neuropathy?
So alcohol can have detrimental effects on the nerves, and by that means, yes, it can worsen neuropathy, definitely. So the answer would be no.
We have time for one more question. Yes, please. Yes, Irene.
Okay.
And so, is there a disparity between the harm of hyperglycemia to your sympathetic system and parasympathetic system?
So the whole mechanism of erection is extremely complicated. So you have a few centers which are involved. You have a cortical center for sexual stimulation. You have sympathetic, parasympathetic, and they're involved with erection as such, with ejaculation, and so it's quite complicated. But in diabetes, the most pronounced mechanism of problems with erection is that suboptimal activity with NO, as well as the small fiber neuropathy.
And is there any way to detect small fiber neuropathy in a very early stage? Because the neuroconductive tests are mainly due to the large fiber that are myelinated, not the small fibers, right?
That would be quite...
Instead of the skin nerve ending biopsy, right?
I wouldn't see any point with the appropriate history and with loads of different treatment options. I think that would be because all of those tests are quite intrusive. So if you have something which could be causing, like you have diabetes, which could be causing the problems you have, I would try to treat them before I would try to say, oh yes, this is related. But if the symptoms are a bit overlapping, yeah, that would be a way to go. No worries.
So thank you very much once again, and now we have to continue. Yes, thank you.